Hi, my name is Gurkamal Valuable, and today I will be exploring a subtopic of the disease Duchenne muscular dystrophy, and how it relates to various research methodologies, and how those research findings work within and interact with various parts of the human body. To achieve this goal, we will be exploring cardiac function in DMD patients, and the story of how cardiac research has affected patients with DMD, focusing specifically on prescribed drug treatments. We'll be learning about the origin and pharmacology behind the most common drug treatments for DMD, while also delving into new drugs that are still in clinical trials. Now, what is cardiomyopathy? To begin diving into this topic, we will begin with an overview of cardiac function, including this excitation-contraction coupling of the heart, and then move on to the effects of commonly prescribed drugs on the physiology of the heart. The heart has a unique conduction system due to the way the deoxygenated blood needs to move into the lungs and back into the heart in order for it to be pumped out again to the rest of the body. Specifically, as shown by this illustration, this process moves from the right atrium, where the deoxygenated blood from the superior and inferior vena cava is collected, to the right ventricle through the tricuspid valve. The blood is then reoxygenated in the lungs after being pumped through the pulmonary artery. This oxygenated blood is pooled in the left atrium, where it passes through the mitral valve and is then pumped out to the aorta by the left ventricle. This entire process proceeds due to the unique innervation of the heart. The heart pumps due to electrical impulses, like any other muscle in our bodies, but the rate of this pumping is controlled by specialized cells in the sinoatrial node that depolarize spontaneously and act as the cardiac pacemaker. The cardiac impulse originates from this sinoatrial node, also referred to as the SA node, and spreads throughout the right and left atria. The electrical impulse travels to the atrioventricular node, aka the AV node, and from there the impulses are slowed down for a very short period. Then they continue down the conduction pathway via the bundle of His and into the ventricles. The bundle of His divides into right and left pathways, called bundle bunches, to stimulate the right and left ventricles respectively and cause them to contract. This overview of how the heart functions allows us to take a closer look at how DMD causes cardiomyopathy. The form of cardiomyopathy seen in DMD patients is called dilated cardiomyopathy, which is defined as a condition in which the heart becomes enlarged and cannot pump blood effectively. In this case, it is the result of damage to the myocardium and is evident in the declining ejection fraction. Normal ejection fraction is approximately 60%, but with DCM, the left ventricle has weakened and become enlarged, causing the ejection fraction to be much lower. This disease will eventually lead to congestive heart failure, and thus the main goals of treating cardiomyopathy focus on controlling the symptoms to promote a normal quality of life while also managing any conditions that could cause the disease effects to worsen. To this effect, many medicines are now used to treat cardiomyopathy. These cardiomyopathy treatments include all the following shown on the screen, but we will be focusing on the effects of steroids, as steroids are often used to treat DMD, and of ACE inhibitors. Although the Watson lectures have already provided a basic overview of much of the information stated previously, we will now be delving into more detail about the pharmacology behind these two drug treatments we have chosen to focus on. For steroids, we will be covering the interactions of prednisone and deflazacort in the body. Both of these have been shown to maintain normal ejection fraction of the left ventricle and thus decrease the chances of developing dilated cardiomyopathy. But how do they do that? For prednisone, it acts as a glucocorticoid receptor agonist. It is first metabolized in the liver to its active form, prednisolone. Prednisolone then crosses cell membranes and binds with high affinity to specific cytoplasmic receptors. The result is inhibition of leukocytes at the site of inflammation, causing interference in the function of mediators of inflammatory response, suppression of the humoral immune response, and reduction in edema. This effect is consistent with what we know about glucocorticoids, in that they mimic cortisol, the natural stress hormone. Due to this mimicking factor, it reacts as cortisol does, and so prednisolone affects what are perceived to be non-essential body functions in a stressful situation. This results in the suppression of inflammatory responses. The anti-inflammatory actions of corticosteroids also involve phospholipase A2 inhibitory proteins, aka lipocortins, which control the biosynthesis of potent mediators of inflammation such as prostaglandins and leukotrienes. For deflazacort, we have considerably less information on its mechanism of action. What we know is the following. Deflazacort is a corticosteroid prodrug whose active metabolite 21-desacetyl deflazacort acts through the glucocorticoid receptor to exert anti-inflammatory and immunosuppressive effects. Despite the lack of further information on the actual mechanism of action, we know from studies done comparing the two that the deflazacort has a potency of about 70 to 90% of that of prednisone. Now, moving on to the next category of drug treatment, ACE inhibitors or angiotensin-converting enzyme inhibitors. Although newer ACE inhibitors differ from older ones in terms of pharmacokinetics and metabolism, all ACE inhibitors have similar overall effects on blocking the formation of angiotensin II, and so we will be looking instead at the generalized mechanism of this blocking. As we know, ACE inhibitors produce vasodilation by inhibiting the formation of angiotensin II. Thus, we must first understand the mechanisms and effects of angiotensin II. This vasoconstrictor is formed by the proteolytic action of renin, which is released by the kidneys to cause circulating angiotensinogen to form angiotensin I. Angiotensin I is then converted to angiotensin II by angiotensin-converting enzyme, or ACE. Angiotensin II constricts arteries and veins by binding to AT1 receptors located on the smooth muscle, which are coupled to GQ protein and the IP3 signal transduction pathway. Thus, by inhibiting the formation of angiotensin II, ACE inhibitors act as vasodilators. ACE inhibitors also block the breakdown of bradykinin, a vasodilating substance, thus increasing bradykinin levels and the vasodilation action of the ACE inhibitor. This vasodilation is important because it reduces the afterload and preload of the heart, and thus improves the oxygen supply-demand ratio. Now, moving on. The new drug treatment we will be discussing falls outside one of the categories we listed before. Instead, it uses coenzyme Q10 to affect heart function. Idebenone is a synthetic analog of coenzyme Q10 and is a powerful antioxidant and essential constituent of the processes of energy production on the cellular level. It can protect mitochondria from oxidative damage and boost their impaired function. It is thought that this mechanism will slow decline in heart function that is part of Duchenne muscular dystrophy. This pilot trial is designed to investigate if this drug will help patients in terms of muscle strength and respiratory function. 21 DMD patients aged 8 to 16 participated in this double-blind, randomized, placebo-controlled clinical trial. The results showed that idebenone reduced the loss of respiratory function and now represents a new treatment option for patients with Duchenne muscular dystrophy. Thus, by understanding the workings of the heart in both its physiology and pharmacology, we can understand the mechanisms behind drug treatments and formulate new and better ones. Thank you and have a great day.